second episode of the St Vincent's Movember Men's Health Series. My name is Manny, the St Vincent's Movember Ambassador, and today we'll be looking into prostate cancer research and how Movember is helping St Vincent's Hospitals with life-changing research here on campus. Today, I'm joined by the lovely Moses Victoria Pacey from our Men's Health Hub, Mobro Lachlan Gray, PhD candidate at the Garvan Institute of Medical Research, and last but not least, Moses Professor Louise Emmett, who will be presenting to us about her team's work with the Nzp Trial, a study in which Movember is helping to fund. I'll just do a quick intro into Louise about her and we'll get started. So Professor Louise Emmett is the Director of Theranostics and Nuclear Medicine at St Vincent's Hospital, Sydney, a conjoint professor in medicine, University of New South Wales, and clinical research leader at the Garvan Institute of Medical Research. She is heavily involved in multidisciplinary cancer research in Australia, including both imaging and therapy. And without further ado, Louise, please take it away.
Well, thanks very much, Manny. It's a great pleasure to be asked to talk today. And I'm just going to be technologically challenged while I figure out how to share my slides.
You've got this.
And can you see that? Perfect.
Excellent.
Look, so it's great to talk about the Enzolitamide trial. It's something that we're doing in close collaboration with Movember. It's a very large trial, and I'm really excited about what changes it's going to bring to practice for men with prostate cancer. So the Enzp trial is actually not just being run at St Vincent's, but we're running it at 15 sites around Australia. And it's about treating men with metastatic prostate cancer who are a little bit further along in their disease, and whether we can actually improve patients' outcomes. But perhaps before I talk about that, I just want to talk a little bit about my specialty and how we got to the Enzp trial. So in fact, I run the theranostics unit, and that theranostics is actually a composite word for therapy and diagnostics. And it's about using these really clever new little proteins that bind to cancer cells that we can use both for imaging. So we use it for PET imaging, and then we can also clip on a nuclear warhead and actually use it for therapy as well. And we've been doing progressive trials in this space in prostate cancer since about 2014 with really, really great results. So for the Enzp trial, we're actually using an element, a radioactive element called lutetium-177, and we label that to Psma, which is a peptide that binds, it's a receptor on the prostate cancer cell surface. So the advantage of lutetium is it's something that we can inject, so we don't have to give external beam radiotherapy. It finds the cancer cell directly, enters the cancer cell, and then acts as a nuclear bomb within the cancer cell itself. So we can give this as an outpatient therapy. It gets really rapidly excreted from all the other areas of the body, so it's really, really well tolerated. We actually started this journey with this little prospective trial that we did in the first 14 patients that were ever done at St Vincent's, and among the first few patients that were treated in the world with lutetium Psma for metastatic prostate cancer. And that was a really, really interesting journey for us. And this is one of the patients. And what you can see, the rotating images here are the lutetium itself. So the lutetium Psma, we can actually image it while it's doing its treatment work. And this is a patient who came from the Central Coast who had really extensive metastatic, so bone disease and quite a lot of pain, and had failed all previous treatments. So we did a PSA, which is to measure how much cancer there is in the blood prior to his first injection, and then did it again 6 weeks later when we gave him his second injection. And he had this really amazing response. And what you can see on the images, we had a good reduction in the amount of cancer that you can see on the images as well. So this patient did very well. But we actually didn't do that well in all the patients. And you can see those patients in red there are patients who didn't respond at all to the treatment. So while some patients, the patients on the line underneath actually had quite a good response, 36% of patients had a good response, we didn't get such a great response in all the patients. And it was really a disappointing trial, and it pushed us to want to be a lot better than we were with this particular trial and do something for the patients. So one of the things that we learned was we actually had to choose the patients more carefully. So we started making sure that patients had really bright disease on the PET scans that they had before they got enrolled into these trials. And we also used another type of PET scan to make sure that all of their cancers actually had the receptor that we needed. So that definitely improved our treatment responses. But the other thing that we really learned from this trial is even though we were getting a really high radiation dose to a lot of the cells and we were getting a lot of disease into these cells, some patients just weren't responding. And that's probably because they have what we call radiation resistant. You can give a really high radiation dose to the cancer cell, but the cell's not dying. So that was another important lesson to this really early trial. And we went a whole lot of different ways in terms of trying to answer those, trying to improve the treatment and answer the questions as to how we could improve the treatment. So actually the next thing we did was a combination trial. We actually added a radiation sensitizer at St Vincent's to lutetium PSMA in 56 men. And our treatment responses got heaps better. So the majority of patients actually responded. And not only did they respond, but they responded for a long time. So we knew from that trial that we were on the right track. If you add things together, you actually get a better response than if you use lutetium PSMA on its own. And that's a trial that we've been published. And this is what it looks like. So this patient was Pat. He came also from the Central Coast. And he had very symptomatic disease at the time that he turned up in 2017 to go on this trial. His PSA was 160 and he had multiple sites of disease in bone. And then if you look at when he actually went off the trial, if you look at the images on the left, there's lots of really gold bright spots. And then if you look on the right, you can see they've all gone. And in fact, his PSA went from 160 down to 7. And I think the best thing about Pat, or the thing that I really remember, is him telling me about how he could mow the lawn again. And that was a big thing for him. Not such a big thing for me, but it does seem to be a big thing for a lot of people that they get the energy back to be able to mow the lawn again. And he actually did really, really well. And his disease didn't come back for a full 20 months after he went on the trial, which is a long time. But there's some really great work that's being done around the world. And this is one of the cases that actually showed that the receptor that we're targeting can actually be, you can actually express more of the receptor based on using different drugs. So you can play in terms of getting people to respond better or worse. So we actually did another trial at St Vincent's where we got all these men to come back, not just once, but 4 times for PET scans. So they had 4 PET scans within a month, these 15 men. So we could actually track what was happening to the receptor so we could best choose how to team it up with therapy and make the therapy work best. So very, very grateful to all these men turning up, having cannulas putting in and having all of these PET scans. But it was really incredible. It gave us all this information that meant we could design the Nzp trial. So this patient actually turned up with metastatic disease, and they've got a single site. I don't know if you can see my arrow here. I've got a site and disease in bone, and they've just been diagnosed with prostate cancer, and they went on treatment with hormones, and you can see it's actually turned off completely by day 9. That was really important. What it means is the PSMA target doesn't stay if you're just at the beginning of your journey. It's much better if we team it up when patients have got what we call castrate-resistant disease. So this patient had already failed hormones and was going on another treatment, and you can see they've got metastatic disease in bone here because it's a really bright spot. They're going on a very good, really powerful treatment, actually. And when we put them on as treatment, suddenly you can see hundreds more bright spots. That was only day 9 afterwards. That patient's not got disease that's progressive. It's to do with the way the receptor is going up or down, expressing more, expressing less. So we have this very complex process going on. And what we decided, we came up with a whole lot of hypotheses about whether the receptor is going up or the receptor is going down and what it means for these patients. And that's really where we came up with the Nzp trial. So the idea of the Nzp trial is to team up treatments that work better together. So we put them in a specific treatment space, and in this case, it's in men who have metastatic prostate cancer who've already failed hormones. And then if you team the hormone up with the lutetium PSMA, you get this technically a nuclear explosion within the cell. You get much, much better cell kill than you would if you used either of the treatments on their own. And that's what this is about. So the enzalutamide is the treatment on the Nzp trial that we're using, the hormonal treatment. It's the key treatment. It's a very active hormone. What happens is if you give enzalutamide to a man who's got metastatic, what we call castrate-resistant prostate cancer, so more later stage of the journey, and you put them on enzalutamide, the cells that are not going to respond to that treatment actually express heaps more PSMA receptor. That means they're much more likely to respond to the lutetium PSMA that we give. And then once the lutetium PSMA knocks off all those really PSMA avid cells, we're left with the clonal population that does have much PSMA at all. That responds much better to the enzalutamide. And you go around in this positive cycle between the two treatments until hopefully you don't actually have any disease left at all. And that's really what the Nzp trial is trying to do. So it's what we call, we're randomizing patients. So patients get one of two arms. They either get enzalutamide alone, or they get enzalutamide plus lutetium PSMA, which is the nuclear warhead that we're using to target the cells. And the other aim of the Nzp trial is really to do a lot of translational work. So we're doing this trial, we've got lots of endpoints from this trial, but we're hoping that we can then, from all the information we get in this trial, design better trials in the future. So to that end, these patients are actually we've got 160 patients being randomized to the trial, but we're actually doing 960 PET scans at different time points so we can get different information from these patients. And they're getting circulating tumor cells drawn, so they're getting blood drawn at each time point from the PETs, and that's going to America. In fact, we have to send live cells to America. So with each of these patients, every time we do a PET scan, we actually draw blood, we put it on a plane, and we send it to America, where it gets analyzed to look to see what the genetic signature is like. So at the end of the trial, we'll actually be able to say, I'm really hoping at the end of this trial, we'll be able to say whether a patient should or should not go on enzalutamide or enzalutamide plus lutetium PSMA. Based on all these scans that we're doing, we'll be able to predict which patient should have what and when. We're actually doing lots of analysis of all these PET scans at St Vincent's, and we're developing these complex ways of looking at the scan so we can actually measure volume and what we call phenotype. And that's a big part of the trial, and we have a lot of PhD students helping us. So this is one of the patients on the Msp trial. He actually had bone disease, quite extensive symptomatic disease in bone with a PSA of 140. So 15 days, he gets a PET scan done again. These are PET scans that I'm showing you after starting the enzalutamide. And you can see it's all a bit brighter. So everything's got a bit brighter. The PSA has actually responded, but all the spots are looking a bit brighter, and there's a few more of them. That's what we call upregulation. This patient actually went on to the enzalutamide plus lutetium PSMA arm. And after day 92 scans, so a 3-month scan, he had no disease left. So everything's gone. And in fact, his PSA was undetectable as well. And that was 14 months ago. So this patient still has no measurable disease. Nothing's come back, which is great. And we have a few patients like that on the trial. This is another patient on the trial. His PSA is 362. He's actually got disease in lymph nodes and in bone. On the day 15 PET scan, he's upregulated as well, so his PSA is brighter than it was, but his PSA is actually responding. So he's having some treatment response to the enzalutamide. He actually drew the enzalutamide alone arm, and so at 3 months, he has 100 new lesions. His PSA is actually doubled, and he's progressed. He's feeling very sick. So we actually took him off the trial at 3 months. And at St Vincent's, because we have a clinical program, we were able to offer him some clinical compassionate treatment. He got 2 doses. He's from Wagga, actually. He turned around after the day after that PET scan was taken at day 92, drove the 5 hours back. We were able to inject him with treatment off trial. He got 2 doses, and his PSA went down to 0.32. And his PSA, that was 9 months ago, and his PSA is still dropping now. So we're managing to help men on both arms of the trial. So Enzp is really about precision medicine. It's about targeting the right patient to the right treatment at the right time. And what we're doing is we're using these paired PSMA imaging and therapy agents really to optimize men's outcomes in metastatic prostate cancer. We're also trying to develop better decision-making tools using imaging and genetics for men with metastatic prostate cancer so we can predict who should be on what treatment. That's a really big part of the trial. And we've got a lot of translational research happening. That's why we're sending all these cells to America. So we can try and determine why men fail treatment. So we can actually we can get better at treating them, and men can live longer, better lives. And, so Enthalpy was funded by Movember and the federal government, and with funding also from St Vincent's Clinic Foundation. It's really taken a village. It's been run by Nzp, a trials group across Australia. And I think it's a wonderful process. Really grateful to be part of it. So now I'm going to stop sharing. Can I do that?
Fantastic work, Louise. That's amazing. I'm just curious to know, with prostate cancer, a lot of us tend to think that it's mainly just older men, but have you seen younger men come through this trial more recently?
Yeah.
Or
So the youngest person I have on this trial is 48.
mm-hmm.
And we do have a lot of old men. In fact, we have the oldest person on this trial is 97.
Wow. Gosh.
Which was a stretch. I think, he might be struggling a bit. But we have, people, it is a fallacy that only old men get prostate cancer.
Yeah.
We have lots of men who are really young, who have so much more to live for.
Yeah, and it's good to see that even a 97-year-old is still, wanting to fight for their life. It's really inspiring. And has it really changed the quality? I was really inspired by when you shared about Pat and how he's able to mow the lawn. And has it really changed the quality of life for the patients that you've seen come through this trial?
Yeah. So you have to be very careful in randomized trials. You're not allowed to talk about outcomes until they're actually finished. So I am gagged, but I have the wonderful advantage, because so many PET scans are being done in this trial. I get to look at how everyone's going, and I get to see how they're responding with all the different time points on both arms of the trial. And no, I'm so convinced that we've made a real step forward in this. The trials that we did before with lutetium Psma were very much more end stage, so they were after patients had already failed chemotherapy. The big step for Nzp Trial is we're doing it before men have chemotherapy. So the idea is whether we can delay the time at which they need to have really strong systemic agents, whether we can make them feel well for longer and keep their quality of life really high. And I know that the patients that we've got at St Vincent's in the Movember Trial, we've absolutely done that.
Wow.
Louise, just in terms of the metastatic patients, I mean, we know it's really effective in these ones. Do you see any future direction in the more acute patients that would traditionally have surgery or radiotherapy?
Yeah, it's really a good question. And so one of the things that we did, and I think I showed a couple of slides on it, where we took patients who were early in the journey, and we looked to see, we did the 4 time point PET scan to see, what happened to the receptor. And it actually turned off with the hormone treatment. So if we don't have a target, we don't get a good treatment response. And I'm very nervous about moving. So there are trials where they're moving it earlier, but I'm quite nervous about moving that earlier without knowing more about the biology of PSMA. And I think one of the things I really like about Nzp is it's looking at the biology at the same time that we're doing the therapy, so that we can try and design the next better trial. And we haven't got that in the earlier space. We don't have trials that look at the biology of PSMA. We don't have trials that look at whether it's upregulating, downregulating, whether there's enough of a target in PSMA early to actually get a good treatment response. So I'd say at the moment, I don't think we're going to be moving it. We'll be moving it earlier in some men who really need the help early on, who have very aggressive disease very early on. But I think most men who have surgery and can be cured, or who have radiotherapy and can be cured, this is not for them.
I'm sorry. I was wondering something that you mentioned in the presentation about how, because this is such a targeted approach, the sort of like side effects of this treatment. Speak more on that. What is the typical experience of someone undergoing this trial?
Yeah, so Enzolitamide itself, the hormone that's been used clinically as standard of care, it has some side effects. So it actually does make some men cognitive function, so the way they think can just go down a little bit, and hormones themselves can make people less active, a bit more tired. But with the lutetium Psma, the major side effect is dry mouth. And the reason for that is because it actually affects the salivary glands. You get a bit of a radiation damage to the salivary glands, because the salivary glands have got the same receptor as prostate cancers. Paradoxically, don't tell me why. No one's ever figured that out. And so you get mild dry mouth. You can get, some men get mild fatigue. And if men have got really extensive bone disease, it can cause mild anemia, but only after 6 doses. What we're really trying to do in Enzp is to touch the earth very lightly with the lutetium, so only use 2 or 4 doses. We've previously used 6, and that's about minimising side effects and just using it very judiciously. So in fact, the side effect profile is great.
That's great to hear.
So would you be using, so with this one, you're using the hormone therapy as well as the theranostics. Are you using the same sort of dosage of that hormone therapy?
Yep. So we're using full dose of both because we really want to maximize the response. In fact, the Nzp trial has been placed in a group of men who have risk factors for early failure on enzalutamide on its own. So we're looking to see if we can take the bad players, the players who are not going to do as well with just hormone therapy, and if we can make them do as well or better than those patients who, who have no risk factors, essentially. So, full dose, absolutely full dose.
And are they given together, Louise, when they go in for the treatment, or is the enzalutamide given at a separate appointment?
So the enzolutamide's a tablet, and it's given every day. So we start the enzalutamide, and then we give them 15 days of enzalutamide, and then we start the lutetium PSMAs, and that's an injection, and they come in to the hospital for that as a day patient, and then we give another dose of enzalutamide 6 weeks later. So the enzalutamide, of the lutetium 6 weeks later, the enzalutamide is just a continuous daily tablet that they take, and we start the enzalutamide first because, in fact, we actually want to trick the cells. It's all about playing a game. We trick the cells into thinking that they can overcome the effects of the enzalutamide by expressing more PSMA, and then we knock them off with the lutetium 15 days later. And that's really fun, actually.
That's cool.
As a theory, it's this idea: can you play with the cell's mind, really? And the answer is, I think the answer is yes.
Wow. And it's so interesting that you can, I guess in my research, I do a lot of computational biology. So when I'm talking about upregulation, I'm talking about numbers. So it's quite interesting that you can see this up and down regulation from these PET scans. It's just so, I find that very, very fascinating that you're doing this across these time points and creating all this extra data points and all these,
Yeah, I had to find a very bright PhD to help me, actually, because in fact what happens is we're tracking everyone at a lesional level. So in these patients we have 160 patients, but perhaps each patient's got 30 metastatic deposits or sites of disease, and we're tracking every single one of those, and then we're correlating that to the circulating tumor cells and the genetics as well. So I'm not sure what'll come out of that translational component, but it's really a massive translational component.
What technology is using to kind of measure that, Louise? Is it with an AI algorithm, or is it just manually done by the PhD student?
Or me, actually. So we've teamed up with a biochemical engineering company in the States to help us develop these workflows. And so we take the PET scans, and we've been developing these workflows that help us track lesions and then quantify the tracked lesions. And that's been a really fun process in the last couple of years. It's actually like playing Sudoku. You have to get in, and then you have to tell the algorithm exactly what each of those lesions is, whether it's cancer or not cancer, and then it tracks them all for you. It's fun. It's like, Pokemon.
And how many people are in the trial at the moment? Are you still recruiting for more, Louise?
Yeah, absolutely.
How do people get in if they want to?
So the oncology, so across Australia, oncology is deeply involved in this trial, and they see patients and consent them and refer them. So it is 15 centres around Australia that is involved. So I think the only state that's not recruiting patients at the moment is the Northern Territory, but we're recruiting otherwise. And they have to fulfil the criteria, have a discussion with their oncologists, and then get enrolled. So we have 101 out of 160 patients who've been randomised to the trial now. And we should be finishing, I'd say, Q2 of next year.
Wow.
Yeah,
more than halfway. That's
end of an era. But then the analysis of all the PET scans and the circulating tumour cells and stuff is going to go on probably for another year after that. And then hopefully we'll publish some really great data. And the big thing out of this is whether we change practice. We have to be able to prolong men's lives, and we have to make the quality of life better. Otherwise, it's no use, doing these really expensive treatments.
And I suppose that's the whole movement with Movember as well. It's about changing the face of men's health and being able to, and making sure that men are able to also live longer and healthier lives. And
Yeah,
also
I think
yeah.
I completely agree with you. The initiative from Movember in terms of putting out these PCRAs, there were 3 $5 million grants that they came up with. And I think they're just going to provide so much information for men, not just in Australia, but worldwide. These trials are practice changing and they're relevant to everyone. So great work, Movember.
Yes. Are there any other patient stories that you're able to kind of share with us, Louise, or are you not able to kind of share that at the moment?
No, but I really would like to talk about how Movember hasn't just funded the Nzp trial for us. We also did another trial with Movember earlier where we were looking at improving treatment. Well, we were looking at to see whether we could predict better treatment responses in men earlier in the disease. And that was called the Prostate Trial, and we ran that across Australia, Canada, and the UK. And that was also just an amazing trial. So I think that, people grow moustaches and it's really fun, and it's a great way to raise money and raise awareness. But in fact, the outcomes from Movember trials are very, very significant.
Absolutely, definitely is. And it's great to see that organisations like Movember are supporting in this life-changing work, and we can't do it without them. So it's really good to see their support, and they're continuing to support us here. And it's great, and I'm sure that it would be wonderful for us to share that information with them, and I hope that this information can help someone down the track by watching this and being informed. And I suppose that's also part of the movement, is to share information and make sure people are learning and growing more than just the Mo, but also their mind and information and research that's happening in this space.
I agree. It's a positive cycle, isn't it? We help them, they help us, we help them, they help us. Everything gets better.
Lockie, Tori, do you have any other final remarks before we wrap up this episode?
Not from me. I think it's just a really exciting area, and I've been working with Louise for the past 6 months or so, and we're really excited to see where this sort of takes us. Yeah,
agree.
And the Men's Health Hub, Tori, is that are you guys working together on that with the Men's Health Project, and what's some other previews that you can share?
Louise is doing a lot of work in this. We're doing some great things more around the supportive care around this. So we know that prostate cancer itself and the treatments have a lot of side effects. Increased risk of suicide in the first year after diagnosis, particularly when having things like hormone therapy. So we're doing what we can to support men from that side of things with supportive care.
Excellent. Well, that's all we have today, folks. And thanks for joining, Louise, Tori, and Lockie. Really appreciate your time taking it for coming on board today and sharing some of your passions as well, Louise, and with your research.
No problem. Thanks very much for having me.
Thanks.
Happy Movember.
Happy Movember.
Happy Movember.